Hello. Hello. Alright, so that should be fine. We gotta do some cards, bro. What are three situations where patients may get an exercise stress test as part of pre-op evaluation? So we're looking at some high-risk spicy tacos. Some red flags, and some vascular surgery. I don't know how the hell you thought of that. What are the wonder drug-related causes of post-op fever? So we're looking at antibiotics. We got some sucks. Actually, this is hard to do. And like, I need some dark mode. Let's go dark. Alright. Antibiotics, heparin. Where's your heps? You got the Van Gogh. You got the Van Gogh, dude. What's the Van Gogh for? Malignant syndrome, malignant. Sucks is for that. Okay, fine. Sedative, antibiotics, blood transfusion. I see blood. I do see the blood. Okay, this is a little difficult. Okay. What are two tests used to work up patient high risk for perioperative cardiac event? So you have exercise stress test, and you have echocardiogram. Okay, exercise stress test, echocardiogram. Okay. Artery supplies a majority, 85% of blood flow to the brain. Internal carotid artery. Okay, internal carotid artery is about 85% blood flow to the brain. Okay. Carotid artery. What are the four types of blood product transfusion reaction that cause post-operative fever? It says febrile, non-hemolytic. Okay, there's some acute hemolytic transfusion reaction. Delayed and allergic product transfusion. That is a little hard. Yeah, it's not. This is kind of boring. Patients who are high risk for perioperative cardiac event based on functional status. So you have high function, which is like, how do you know that? 4. Then you have like high risky. Then you have required. Okay. This is for what? Cardiac event. Okay. And then in aortic dissection, how can you differentiate the true lumen from the false lumen on CT? I don't know. The true lumen is smaller, rounder, with more dense contrast. Oh, you're talking about aortic dissection. What? Oh yeah, you have like this kind of weird like false and true lumen kind of thing. Actually, you know what I need? You know what I really need, bro? Let me see how my OBS handling. Chat rate? Well, there's no chat rate, bro. There's like no chat rate right now. So we're looking at some artery supplies. Majority of blood flow to the face. So we have to kind of remember external. Carotid is internal, and is it like external? Okay. Pathogenesis, febrile, non-hemolytic transfusion reaction, excess of cytokines within transfused blood products. Okay, that's kind of weird. And you have 2 medications to change continuous periodic cardiac risk management. So what is that? Beta? Where's the beta? We got the beta blocker. What is this for? Cardiac. Kind of weird. Okay. And you got statin. Statin. Okay. Alpha glucosidase inhibitors infrequently prescribed. There's a. Oh yeah, because it causes severe abdominal side effects. Okay. And then you got name 4 signs and symptoms of acute gastropathy. You have nausea. You have emesis. Okay, you have epigastric pain, melena. Okay. Nausea, emesis, epigastric pain, melena. Okay. Chapati, there's NSAIDs that can cause it. Makes sense. Iron. Where's your Asaki? Okay, alcohol. Chemotherapy. And cocaine. Okay. Major trauma, shock, sepsis, or serious illness can cause what type of gastritis? Stress gastritis. Trauma, shock, sepsis, or serious illness can cause what type of gastritis? Stress. Okay. Usually shows petechial hemorrhage and erosion through the stomach. What? What is this? Oh, whoa. Erosive gastropathy. Plant is a toxin derived from digitalis. Oh, whoa. No one cares which plant. Heart rate and bradycardia. So you have less than 60. Yeah, we kind of know that. And even men, women. Woman is, I think, 11. Men is 12. Never mind. Woman is 12. We're 13.5. Oh, that is a different one. 13.5. Oh wow. I'm kind of feeling sleepy. Well, I just started. I think it's like less than 1:35. Yeah. Yeah. That's kind of cool. Criteria to meet for the item CKD. I don't know. What do we have? A 3 month thing of what, GFR? Less than 60. Where's the 60 mentioned? Nowhere. I assume. Oh yeah, there's 60. Okay, so it's like for 3 months or more than that, GFR less than 60. ml per 1.73 meter square. It's like an objective kidney damage. Okay. Like the pathogenesis of rheumatoid arthritis. So we're looking at autoimmune. It's systemic inflammatory disease. Okay. Neuroblastoma presentation, we're looking at 18 months. Oh, neuroblastoma is 18 months. Months, by the way, months, not years. Okay. For Wilms tumor, no memory. How does it develop? I don't know. Neuroblastoma. Embryonic tissue in the kidney. Embryonic tissue in the kidney. And persistent embryonic tissue. Oh. Okay, it comes from nephro. Most common renal malignancy in children. Alright. And severe hypokalemia. Vendor systems manifest. Kalemia less than 3.5. Symptoms are less than 3. Severe less than 2.5. Okay. Less than 2.5. Symptoms less than 3. And this is less than 3.5. Okay. There's MCV normocytic anemia. 80 to 100. I mean, how are you supposed to remember that? Well, you kind of have to. What are the triggers for acute CPP crystal arthritis? Crystal arthritis. Good question. I don't know.
4.
Well, that's kind of weird. What are they saying? So we have monosodium urate crystals. What is this right here? A urine breakdown. Uric acid, and of course, under-excretion by kidneys. Too much uric acid and under-excretion. Basically gout. Okay. Gout. Gouty. Gouty boy. You're gouty. Most common presentation of a neuroblast. Did they talk a little bit about it? I don't know what they say. So 3 years old, one could be like that. Or 2 years old with hereditary cause. More common in black children. Wilms tumor. Okay. Symptoms of hypokalemia are skeletal muscle weakness, ascending paralysis, muscle cramps, muscle weakness, ileus, arrhythmia. Okay. Hypokalemia can cause skeletal muscle weakness. Tight painful leg, hypokalemia can cause muscle cramps. Skeletal muscle weakness, muscle cramps. What's other thing? Respiratory muscle weakness. Any supraventricular, ventricular arrhythmia. Hypokalemia can cause ileus. There's ileus, there's supraventricular arrhythmia, muscle weakness, muscle cramps, and ascending paralysis.
What demographics are typically affected by gout?
Well, no one really gives.
What demographics are typically affected by gout?
There's what are we looking at? We got some middle-aged people. Well, there's no woman. Okay. Obesity. You can mention obesity. What are signs of spinal cord decompression? What? Change in gait. Do they have an image of gait? Oh yeah, they do. Bowel bladder dysfunction. Yeah, okay. We have decreased strength, sensation, and loss of reflex. They're gone, bro. They're gone. Wilms common tumor. We're looking at abdominal pain. What's the other thing? Hematuria. Looking at, what is this? Fever and fatigue. Fatigue, palliative anemia. Abdominal pain, hematuria, fever, fatigue, or palliative anemia. What muscle-related complication arises from hypokalemia? Rhabdomyolysis and rhabdomyolysis. Okay.
How does acute gout typically manifest? How does acute gout typically manifest?
Okay,
6.
This voice is kind of annoying. So we're looking at joint pain. There will be some tenderness, some warmth, Some pain usually affects the first metatarsophalangeal joint. And fever, you could have some restricted range of motion. Night. Actually, that I might have to know. Night. Yeah, sleep. You're right. Yeah, at night. At night. Yeah, good point. Good point. All right. Yeah, we should just remember fever and stuff like that. So chief complaints and presenting illness and neuroblastoma. You'll come with fever. Kind of looks a little. There's some weight loss, and you can see pallor. You look pale. You look pale. The Wilms tumor. Tumor Wagger, Dennis Drage, Beckman, Weidman syndrome. Wagger. So you have Wagger, Dennis Drage, Beckman, Weidman syndrome. Okay. Okay, well, you know what? You know what I should do? You know what I should really do? Drink some coffee. Let me go get myself some coffee, dude. Let me go get myself some coffee. Oh, bye. Oh wow, this is fine. Alright, I'm back. I'm sorry, that took a while. I just wanted to drink some coffee. Okay. Characteristic ECG findings. Hypokalemia. Let's go. What are you looking at? Quiet. QT is prolonged. What the hell is this? There's a U wave, flattening of the T. I see depression. Increased U wave, flattening of the T. I see depression, prolonged QT. Nice.
How long do acute gout flares last, and how often does they recur? How long do acute gout flares last, and how often does they recur? 2.
Wait, maybe I should lower this up. How long do these flares last? Okay, last 2 weeks. Let's find out. 2 weeks, nice, and recur within 1 year. Okay, polyarticular, that's kind of cool. We're looking at elevated. What are we looking at? We've got the Maltese, tumor lysis, hypercalcium. Well, yeah, that's in the thing, bro. Come on, bro. Banana paste. They thought banana paste was a good idea. Funny. Elevated ferritin. LDH. Characteristics Wagger syndrome. There's Wilms. We got Wilms. We also have aniridia, GU abnormalities, and mental retardation. Okay. What else do we have? What are the three symptoms that cause it? Renal should be 1, GI, and skin. Renal, GI, intracellular shift. Well, I wasn't gonna get that. All right.
What are some triggers for acute gout?
Pure
1.
rich foods. Yeah, you got pure. Okay. Trigger. Pure enriched drink. Crumbling crab. We got major physiological stress. Thiazides. Umpire ASA mask. Nephrotoxic meds. Urate lowering medications. I don't know how that's a medication that lowers it. How am I supposed to remember that? Nephrotoxin makes sense. ASA. Thiazide. Hemolysis syndrome. Okay. Gold standard for neuroblastoma workup. I think we go for MRI. We go for the M. What the hell? M big. What is an M big? Alright. A biopsy. You got some homorites. We got some homers, bro. We got the homer. Homer right. Okay. Characters of Dennis Draft syndrome. It's, what are we looking at? They didn't say anything. Alright. Wilms, you got Wilms. We got renal disease and male pseudohermaphroditism. Well, maybe if you showed it to me, maybe I would get it. You know? Alright. Transcellular shift of potassium leading to hypokalemia. So there is insulin. There is refeeding syndrome. Okay. There's beta tube. And there's alkalosis. There's beta tube. And there's refeeding. And there's insulin. What the hell? What? There's insulin? Oh, wow. So increase insulin. So refeeding syndrome, beta 2. If you take even medication, too much eating. All right.
Which joints and organs are typically affected in chronic defacious gout? Which joints and organs are typically affected in chronic defacious gout? 2.
Kidney. Okay. Did they mention it? I don't know how they're gonna mention it. It's kind of a weird thing. Really, they did kind of do something. Wrists, you have that, and you have base of the great toe. Why is it on his ear? Okay. Urate kidney stones. Any acute urate nephropathy. What are two common genetic alterations in neuroblastoma? ALK and MYC. ALK and MYC. ALK and MYC, okay. Beckwith-Wiedemann syndrome is Wilms tumor. Okay, we have overgrowth of organs, hemihypertrophy, and phallus. So how are we going to remember this? So we have macro, what do we have here? Kidneys are enlarged. We have macroglossia. We kind of have the overgrowth of tongue. We have the Beckman-Wiedemann, Becky. Hey, Becky, hemihypertrophy. Omphalocele. Hey, I like this. Beckwith-Wiedemann is kind of sick. All right. Electrolyte derangements are present in refitness, so we have hypokalemia. Okay. I think it's also an hypomagnesemia. I don't know where that's mentioned, but okay.
What are two important causes for chronic gout?
Chronic kidney disease. Where's that mentioned? Turner, chronic kidney disease. Okay. Shriveled kidney. TARDs. Okay. And then you have lysine balloons. Nice. Okay. And then you have treatment for lower risk neuroblastoma. Just do an observation of like what's the 1 year. Or you can do like a surgery. Hey, we like a surgery. We like a little surgery. Wilms tumor. What are we looking at? We're looking at hypertension. Nice. Looking at some eccentric rarely crosses the midline. That's kind of weird. I'm not going to remember that. Careful. Okay, don't palpate too much. Aniridia. We have Becker-Wiedemann, and we have this one. I think it's just pseudohermal. No, what is this called? Come on. Geo and hemihypertrophy. Oh, they meant hemihypertrophy. Never mind. Oh, that was kind of cool.
What is the diagnosis? What is the diagnosis and follow-up of gout?
What are you looking at? We're going for the leaking knee joint faucet. Okay. And we're looking at parallel needles. We're looking at elevated leukocytes. Less than 50,000. Soapy water, synovial fluid, cloudy with elevated WBC. Check uric acid level more than 2 weeks after acute attack. Surgery, chemotherapy, labs, Wilms tumor, elevated creatinine, hematuria, and you have proteinuria. Creatine. And what left hand can differentiate hyperkalemia to the GI versus renal? Oh wow, that's an interesting point. I don't know. Renal causes have high levels of K+. What? Renal. So what are we looking at? More? That's kind of weird. How are you supposed to remember that? What? What? How does bananas over creatinine head? That means like more bananas. Oh, renal one, the K to the creatine is more. Yeah, so am I. Have high levels of K plus. Okay. Just to go with the image, bro. Go with
What
the
does
image.
X-ray demonstrate in a patient with chronic? What does X-ray demonstrate in a patient with chronic gout?
X-ray. Affected joint. Well, cookie cutter, what does that have to do? What? You call that a cookie cutter erosion? I don't know if you call that. What? What? A cookie cutter? Who wants to call that a cookie cutter? What? Okay, treatment for high risk. We go for the surgery, we go for the radiation, we go for the chemo, bro. So we got some chemo here, mild, medium, moderate. Okay. I like that. I like it. We're going for Doppler, obviously. Cat. Oh, that's it. Oh, nice. Alright, okay. Lab findings are indicative of diarrhea caused hypokalemia. We've got some low urinary potassium, and we have metabolic acidosis. Oh, is that what it was? Metabolic acidosis. Okay.
What is the treatment for acute gout? What is the treatment for acute gout?
We have do not touch. We have NSAIDs within 40 hours. Okay. We have Moonface, inject glucocorticoid, and oral glucocorticoid, colchicine, Quar singing is option for acute flares, and you have oral glucocorticoid for polyarticular acute gout, ESRD. Poorly controlled. Okay. What is the cellular origin of neuroblastoma? Normal growth with neural crest cells and adrenal medulla. Neural crest cells. Okay. What's there more? There's anaplasia. Immature blast cells on microscopy. Yeah, I don't know if we even want to mention it. I don't think even they know. Nah, I'm sure they would. I'm sure like a nephrologist would know the histological findings of a Wilms tumor. Does it come under nephrology? Yeah, sure. It should, right? Or would it come under general medicine? You know what? Never mind. Hypokalemia, we have hyperchloremic non-anion gap metabolic acidosis. Hypokalemia. What? Okay, where's that mentioned? Nowhere. Let's go move.
What is the long-term treatment? What is the long-term treatment of recurrent acute gout or chronic gout?
6 yarn, yes, we love that. Prophylaxis is bad. NSAID, colchicine, PRS and none, allopurinol, febuxostat, probenecid is uricosuric agent, rasburicase, neuroblastoma cause of is located in thoracic cavity. Horner syndrome. Wait, what? Oh, yeah, okay. Yeah, bro. Most common gene abnormality. That was WT1. Yeah, dude. I'm a star, bro. I'm a star. Hyperaldosteronism. No one cares. Okay. Where's that? There's hypertension. Where's the Aldo? Aldo, you're right. We do have it. And of course, metabolic alkalosis. Hey, we love that. Okay.
What is an adverse effect of allopurinol?
Really, it causes hypersensitivity. Where's that? That's actually 13. Where's the thing? Well, you don't have it. Kind of weird, huh? Very weird. B5801 mutation. Okay. Brenner syndrome. 30% mortality, more frequently seen in patients with the B50A1 allele. Kind of weird. There's also some differential diagnosis for other abdominal masses in children. So what are we looking at? Oh, come on. No one cares about different. I mean, we kind of have to, but it's like, bro, come on. No one's gonna read this stuff. Claiming normotensive diuretics. Where's that mentioned? We got some normotensive stuff. We have whatever this guy is doing. Thiazide, diuretics. Oh, what? What was you trying to say? Hypokalemia, metabolic, alkalosis, and normotensive. It could be a diuretic like thiazide, vomiting, Gittleman, barter. Loop diuretics. Yeah, okay. And yeah, but we're not gonna do Gittleman.
What the medical term for pseudogout?
Considerations when administering.
What the medical term for pseudogout?
Don't give probenecid for gout if uric acid is elevated, less than 800 milligrams. Well, where is that mentioned? Well, we're not gonna know. Okay. For other thoracic mass in children, so No one cares. Treatment, Wilms tumor. Hey. Based on staging, but like we go with nephrectomy. Cool. All right, what are we going for? Chemo. We got some chemo and radiation. The three that you would consider for any tumor. So you know what? Primary hyperaldosteronism, aldosterone, renin, and that ratio to that. So we have elevated. What do we have? There's aldosterone. There is low renin. Oh, so it's high. Very interesting. Very interesting. Okay. So
What the medical term for pseudo-gout?
So we're looking at calcium pyrophosphate dihydrate crystal deposition. Oh, that's CPPD. Calcium pyrophosphate dihydrate crystal deposition. Wilms tumor. Fire survival is over 90%. Elevated aldosterone. Vital signs. Hypertension.
What are the demographics for CPPD disease?
Patients are like over 65. Signs of surreptitious vomiting. What does that mean? Dental erosions. That's the best you got? Scarring on dorsal hands. What does that mean? Parotitis. What? What is this? HPI for neuroblastoma. Everyone knows it's respiratory distress. It's constipation. No one thought of constipation. No one thought of that. No, I think cough. Yeah. What is this? Plunger, constipation, and windy whistlers. Respiratory shortness of breath. CC Wilms tumor. Abdominal mass without any other symptoms.
How does CPPD disease manifest compared to gout?
Warm, painful, swollen joint is monoarticular. Warm, painful, swollen joint usually monoarticular. To affect the UE. Where's the elbow? Monoarticular. What causes Bartter syndrome? Am I boring myself? I don't care about you, but I'm kind of just boring myself, am I? 0 views, bro. You're doing so well. You're doing so well. All right, what is this? Bartter syndrome. We're not gonna remember this. Bars, monkey bars. Well, what's that supposed to do with this? It mimics the loops. You mimic the loops. Okay, so I have hepatomegaly. You have blueberry muffin rash. Where's that? That one. Okay. We have bilateral black eyes. We have some opsoclonus myoclonus syndrome.
What are triggers for an acute CPP
Major
crystal
physiology. Where's the
arthritis?
stress? I'm stressed. I'm super stressed, bro. What causes Gittleman syndrome? I think we just did this. No, we didn't. No, we didn't. No. that was very cool, but no. CBC with bone marrow involvement. What? In a neuroblastoma case? Alt. You got yourself alt. Anemia, you got the leukopenia, thrombocytopenia.
How long does an acute CPP crystal arthritis last?
One to 3 weeks if treated. Inheritance pattern of Gittleman and Bartter syndrome, AR. Autosomal recessive disorders, okay. We got the recessive. Neuroblastoma, elevated VMA, vanillin mandelic acid, and homovanillic acid. Yeah, that's
What are the two forms of chronic CPP crystal arthritis?
So, no, you know the rheumatology one is I kind of hate it. I kind of hate it. Inflammation. We kind of know the difference between these. Crystal arthritis, where you're saying pseudo even OA. Whoa, this was new. How's an image going to differentiate that? Sometimes intermittent flares, UE joints, that kind of stuff. Yeah, waxing waning. I'm not gonna get this one. How to differentiate between these two? One is like urine. Oh, really? Oh, wow. So the bars one has low calcium? No, this urine is more. Oh, okay. Through urine, it's more calcium. Okay, nice. This is nice.
What are the 4 H's that increase the risk of CPPD disease and what are the corresponding lab values?
That's
No
not
memory
gonna help in anything. Just showing a kite with 4 H's doesn't mean I'm gonna guess all these 4. Hemochromatosis, hyperpara. Well, like what? You think I'm gonna remember like that? It doesn't work that way. What? Okay. You know what? Well, you did your best. You really did do your best. You know what? I think in one single image is kind of hard. I mean, you could have like there's some gaps here. You could have done I don't know. Could have done something. Whatever. All right. How the difference between a vomiting, diuretic, and Gittleman? Good point. So we go with if you have urine chloride. Oh, it's not. No, just chloride. So they'll both have it, which is this one has the calcium. Okay. Variable. If you just have low urine chloride, it's vomiting. Because it's hypochloremia. No, I don't know. Diuretic uses a variable urine chloride. Doesn't matter. You could not. But vomiting is like low. It's right here. No dumping chlorine. So there's no chlorine in the vomiting. It's in urine. Okay.
How does CPPD disease present on exam?
Erythematous swollen tender joints. There's joint restriction. Crepitus. Well, that's crepitus. Some pain. There will be pain. Regards as hypokalemia, type 1 RTA, type 2 proximal RTA, and hypomagnesemia. Okay, that is a magazine. What is this? Both? You have both. Type 1, type 2. I don't even remember. Oh, type 4 is more. So these are super rare. Rare to a point where no one cares.
How can undistinguished gouty joint from CPPD disease?
CPPD disease. Joint aspiration. Rhomboid shaped, positively birefringent, appear blue. Okay. Appear blue with parallel polarized light. Joint aspiration. A rhomboid shape. Birefringent, appear blue with parallel. I don't know how. Well, there's parallel light, but how am I supposed to know that? Birefringent CV crystals of acute hypokalemia. KCl repletion. Of acute hypokalemia, oral or IV KCl repletion. Am I getting bored? I mean, this is kind of simple. Obviously, if you have low potassium, you give more potassium. Okay,
How can one diagnose CPPD disease on imaging in addition to joint aspiration?
Imaging. Chondrocalcinosis. On X-ray. Oh, okay. Chondrocalcinosis. What am I reading? How can one diagnose CPDs on imaging in addition to joint aspiration? So you'll find that on X-ray. Huh. Never seen it. Well, oh, this is what they're trying to say. Stenosis. I mean, that would be impressive. Oh yeah, there's like a little white line you're not supposed to have. Ratio of potassium, repletion to potassium change. Repletion to change. What does that mean? What does this mean? 10. I love that we can't even get it. Per oral, and there's like 0.1 rise. What does that mean? If it's like 10 rise in the body, if there's a repletion of 10 milliequivalents, it's like 0.1 milliequivalent change in the blood. Oh, that's what they meant. Okay, that's what they meant. All right, dude. All right, I like that.
What are treatments for CPPD disease?
So we just give NSAID, steroids, colchicine, second-line DMARS. Where is that? Okay, this is I want to at least do this. They give NSAIDs. Steroids, you could have given a smiley face. Where's colchicine? You could have done something. Of course, no, actually, you know what? They did. We demartivo, yeah. And chronic hypokalemia. Oral KCl first. Potassium sparing diuretics. Oral KCl first, then potassium sparing diuretics. Reduce GFR. What dose of potassium should be given? Have the typical dose. That's not even half. Well, you know what? They could have done a better job at just, They could just do it right here, just like half it, just half it right here. They went like 3/4. You do if you want to say half, then say half. Why are you going 3/4? If we reduce VFR, what dose of potassium should be given? Okay, not 3/4. If potassium's still low after repletion, what should be done? Okay, IV you couldn't do. Oral you can't do. What? Check for hypo. Oh, is that what happened? The magnesium. Oh, that's an interesting point. What is normal range of calcium? It's like 9 to 11. How do you? This is impressive. How do they do this? I can't believe they made one image like this. 8.4 to 10.2. They made an image like this. 8.4 to 10.2 milligram per deciliter. I mean, what can the reticulocyte count be in normal cytic anemia? Maybe normal? Oh, it depends, huh? 2% is like, depends. More than that is hyper proliferative. Less than that, hypo. Okay, so this is probably how we should have answered it. Okay. And then we have a mechanism of action of cardiac glycosides. I don't remember either. So I think it's digoxin. So what do they do? Where there's you got the 3 P's and you have inhibition of sodium. Well, you have a banana. Where's the sodium? Sodium and potassium ATP. But see, there's a banana. Where's the peanuts? What? Am I missing something? What? Knocked over bananas. Where's the peanuts? What? There's also for some reason a sodium and calcium exchanger. So there's this thing. Okay, that's kind of weird. All right, whatever, bro. Causes of bradycardia. There's so many. Okay, let's go through it. So yeah, you got beta blockers. This is an interesting way of putting calcium channel blockers. Nice, this is nice. Alpha blockers also. Both. Okay, you know it's okay. Parasympathetics. Okay, we have opioid intoxication. That's just toxicity. What is this? Oh yeah, doubles. Hey, cholinergic toxicity. Too much, huh? What else you have? Vagus. Increased vagal tone. What is neurogenic shock? What is this? Cushing triad. That's what it meant. What is this? Radiation. Okay, so hypoxia, hypothermia, anorexia. Well, that's so difficult. That's kind of difficult. You have mixed item of coma, inferior heart lute getting. So what is inferior myo? Okay. AV nodal block. What is this guy? Amyloid armor and sarcoid soccer ball. What? Amyloid. Myocarditis cardiomyopathy infiltrated disease. Why do you do this? Like, this is just come on, bro. Sarcoidosis can cause. Is that what they're trying to say? Ixodes, tick. There's so many. They did so many things here. Like, why did you put a sarcoid soccer ball? They put so many in here. There's a lot. Yeah, there's a lot. So you have Lyme disease, sarcoid. You have amyloidosis, inferior myo, mixed in metabolic, equation driven neurogenic shock, increased vagal tone, cholinergic. Opioid could come under toxicity. Why did they put it there? I mean, it's probably medication, probably. Yeah, that's probably what they did it. Okay. It's 15 causes of bradycardia. That's kind of insane. Symptoms of anemia could be fatigue. It could be dyspnea on exertion, angina. I don't know if people want to call that angina. It's kind of weird, but fatigue makes sense. Dyspnea, angina, whatever. Okay. Hyponatremia. Yeah, I don't know what happens. Neurological and nausea, vomiting. That's it. Yeah, you get nausea, vomiting. Okay. How does early CKD present? Oh, nice. They're happy people. Describe the demographic affected by rheumatoid. It's usually women, 15 to 65. Never mind, it's older. Okay. Well, I was sort of right. They sort of somewhat changed it, but still the same thing. Where are calcium sensing receptors? Outside? No. Okay, where is it? Well, you can't just what? Okay, we know kicking. What? Oh, come on. We can't just. We need an image. Well, you know what? Whatever, dude. What are the 3 effects of PTH on like calcium? So we have decreased renal excretion. What is this? Renal excretion. Well, listen. Obviously, if you're excreting less. What What does PDH do? Does it reabsorbs the calcium, right? Does it, or does it increase bone resorption? Decreased renal excretion. Okay, and then increased intestinal absorption makes sense. Increased bone resorption, that kind of makes sense. It kind of checks out too. On phosphorus, it's the same thing. It's the same thing. It stimulates renal excretion. Really? But also, maybe I'm messing this up. Wow, I really messed this up. Wow. Oh wow, I really messed this up. That actually excretes it. Wow. Yeah, I really messed up there. Total calcium measurement in blood represents what two types? There's bound and unbound. Free. Yeah, that's really it. Okay. What effect will decrease in albumin have on calcium? Well, it's gonna be more. Total will be same. It's just free will be more. Wait, how? You're telling me that even the total will decrease. But no, if it's bound. What? That is a little weird, okay. What does calcium correction use in states of decreased albumin? 0.8. Decrease in total. Oh. Gram decrease in total. What? A 0.8. Every 1 gram decrease is 0.8 in total. I didn't know that. Wow, so it does decrease total. Okay. We can cause pseudo hypocalcemia. If there's like more albumin. Never mind. Decreased albumin. That's the absolute opposite. Well, maybe if you mentioned, I would understand it. Decreased protein states. Anything with less albumin can cause hypocalcemia. Oh. Like malnutrition, nephrotic, and decreased albumin. Anything with low albumin. What effect does alkalosis have on calcium levels? I don't know. It causes hypo. How am I supposed to? Well, is this hypocalcemia? So this entire thing is hypocalcemia. So putting a base actually causes it. Okay. Symptoms of hypocalcemia. Fractures? No. God. Okay, so what is this? Tetany. We have tingling. What else we have? Hyperflexia. What else we have? What? Trousseau. Okay. Okay, Trousseau sign. Trousseau and chef stock. Okay. Nice. And what is this? Fatigue. Okay. Okay. Now, what is the differential for patient with hypocalcemia and low PTH? So, we have iatrogenic, surgery, autoimmune disease. Okay. What lab should be checked after finding of hypocalcemia? So, you check for total calcium. You check for albumin, you check for pH. Well, I mean, thanks, man. You know, really, that was really what I needed. After finding of hypocalcemia, what is the next major branch point during workup? So we're gonna go for high or low pH levels. What the hell is this for? Okay, I'm kind of getting bored, huh? Yeah, I lost the caffeine energy. Yeah, I lost it. I totally lost it. Yeah, I should get some more. I should really get some more. There's like 4,000 cards left. I don't know how I'm gonna do this. Nah, there's always a way to do it, bro. There's always a way. Well, I'm gonna have to like finish 4,000. See my hyperphosphate. So what is this? Calcium decreased. And where's PTH? Well, PTHD, if it's low, what do you get? More phosphate. Okay. And less calcium. Okay. Alright, so we're gonna have to stop.